Hello, hi, welcome everyone. Thank you for joining us for today's CME. My name is Amarjit Kaur, and I am the Marketing Executive at Ara Damansara Medical Centre. Today, we are presenting to you on the treatment strategy for common causes of shoulder pain, presented by Consultant Orthopedic and Sports Surgeon Dr. Shamsul Iskandar bin Hussein. Dear GPs, your active participation is important throughout the session. Here is a housekeeping rule before we get started. If you have any question during the presentation, please type them into the comment box below. I'll bring them up during the presentation and we will have time for question and answer at the end. Right now, can I have everyone on mute and off camera to avoid background noises that may distract you from listening to the webinar? For attendance purpose, please introduce yourself and your clinic at the chat comment below. Kindly be informed, CME points and QR code will be displayed at the end of the session. Here we are presenting to you a welcome note from the CEO of Ara Damansara Medical Centre, Juan Miranda Harumal.
All the doctors gathered here today. I am Miranda Harumal, the CEO of Ara Damansara Medical Centre. It is a great pleasure for me to welcome each and every one of you personally to this event today. It is good to have you with us. To me, this is a sign of your commitment towards your patients and our relationship. ADMC prides itself with regular CMEs for all our doctors in our effort to create better care and clinical outcomes. As a doctor, you are the gatekeepers of medical expertise in hope that you will be able to add value to the care of your patients. We hope you will gain invaluable updates from
Stuck. Computer stuck. Control? What should I do? Should I? No choice. Okay, this is the video. No, no, I need that. Okay, take this. Yes. Thank you. All right, I'm so sorry for the technical glitch. So there was a wonderful message from the CEO. Now, without further ado, we will turn the time over to Dr. Samsul. Our presenter today is a consultant orthopedic and sports surgeon, and he has been with Ara Damansara Medical Centre for the past 7 years with a special interest in sport injury. Let's welcome Dr. Samsul.
Hi, good
Welcome, Dr.
afternoon, everyone.
Samsul.
Thank you. Thank you for the invitation.
So, Doctor, the floor is all yours now. Dr. Samsul, can you hear me?
Yes, I can. Okay,
All right, okay.
to begin with, thank you to our marketing section or department of Ara Damansara for the gracious invitation to invite me to give a presentation or talk with regards to shoulder pain. Before we start with the presentation per se, I will share with you all the survey that we done much earlier to gauge the feedback or basically the experience that most of you involved with regards to shoulder pain. Can you see my face? Okay. So now the earlier questions that was sent by by our marketing team with regards to the feedbacks or the responses that we get. So a total of more than 100 respondents. So as for the first question, we see that a number of our colleagues here do see frequently the patients with shoulder pain. Okay, it's more than 70%, 80%, which is actually reflects the frequency of the patients that we see in the clinical practice. So, so this I will delve in further. And coming to the second question, the the returnees to the clinic with regards to the shoulder pain. So you can see here again that more than 50% in the graph shows 60% who returns with the shoulder pain. But of course, this is within a specific period of duration. It may be within months' time, or can it? So, the question three on questions about performing injections for the patient with shoulder pain. So, well, I think that this reflects basically the number loads of patients that you see in your clinics every day, thereby preventing you uh, clicks in the GP setup. The procedures may be simple or straightforward. Nonetheless, it does take time. So, again, it reflects the current work practice here. For question 4, where the question is about referral of shoulder pain patients to the specialist. Yeah, again, with patients with acute pain, I think naturally these patients can be treated well or managed well by our colleagues in the GP practice. However, there are certain symptoms of signs which you need to know where those patients require urgent referrals. Next, uh, with regards to the question of referring those patients whether to the orthopedic specialist per se or specifically to those with the orthopedic surgeons with interest in shoulder surgeries or basically a shoulder consultant. I think namely in Malaysia, we don't really uh, quite aware with the regards to the prioritizing those patients and these shoulder patients. Although in other countries in the Western countries, US, Australia, they would tend to refer these patients either to the sports surgeons or the sports medicine doctors or even the shoulder and elbow or upper limb surgeons. Finally, I think this is the final questions with regards to the feedbacks that the doctors in the general practice setup refers the specialists who receive their referrals. I think the answer reflects that it's like a 50% is a bit more like equal. Okay. Right. So these are all the questions that have been posed earlier on. Nonetheless, if you have any questions to ask me or to the team, you can do so in the YouTube comment section. Okay. So next, I think we'll start with the presentation. Okay. Yeah. Just let's stop sharing. Stop sharing. Okay. So, okay. I think that's right. So for today, I'll be sharing with you all my fellow doctor colleagues who has taken your valuable time to come and share something about the shoulder pain, which I think most of you will be well aware and be seeing in your clinical practice. Therefore, the shoulder pain actually is the third frequent common musculoskeletal symptoms, other being the back pain and also the knee pain. So, as you can see that in your clinic practice also, you do see a large number of patients with this shoulder pain. And be in mind that there's actually 1% of adults population annually every year who consults for new symptoms of shoulder pain. To adapt to those patients who has been coming to see you before for their existing shoulder pain. Nonetheless, there's many causes of the shoulder pain, and one of them being the referred neck pain, which is of a cervical spine origin. So we have to do take note and rule out these possible cervical or neck pathology before arriving to the conclusion of the local shoulder causes. And here I'm going to share with you the common shoulder underlying causes for the shoulder pain. Firstly, most common, more than 85% of these shoulder pain symptoms is due to the rotator cuff disorders, namely the muscles of the rotator cuff, the supraspinatus tendon, infraspinatus, and then basically the teres minor. So all this, along with sometimes the long hip biceps tendon, which causes symptoms of shoulder pain. Next, we also have the glenohumeral disorders, which you normally see, or I do always get referrals as being frozen shoulders. So this is, I feel that you're also quite well aware in your practice. Again, the other glenohumeral disorders is the shoulder instability or dislocation, which is most of the time traumatic or can even be due to epilepsy or electrical shocks. So this is where sometimes it may require urgent referrals. Okay. Then we also have the AC joint, or what we call as the acromioclavicular joint pathology, whether there is arthritis to the shoulder joint, which can cause chronic shoulder pain, or also the acromioclavicular joint dislocation, which can be an acute traumatic situation. Most of the time, the cases of shoulder pain, majority of them can be treated satisfactorily by our colleagues in a general practice setup. However, the chronicity and the recurrences are very common. So most of the time, there will be 14% of these patients who initially came to see us in the GP setup will still be seeing you back in after a period of 3 years. So in spite of the initial successful treatment, some patients do return to see you with the similar symptoms or even worse. Therefore, the success of the treatment is actually very dependent on getting the accurate diagnosis. And this can only be achieved by performing careful examination and also, if necessary, selective diagnostic testing. So, shoulder, what is a shoulder? I think you and I already know that shoulder is the region which is below our head and neck. Okay, but it's actually complex structure. It has bony structures, the muscles, and also the multitude of ligaments consisting of the which forms the shoulder complex structure. As for the bony structures, it is a combination of the humerus bone, especially the proximal humerus, which is the head of the humerus. Next, you have the scapula, which forms the basis for the shoulder joint. You have the glenoid part of the scapula. You have the coracoid process. You have the acromion process, the wings of the scapula or the shoulder blade. Then you also have the collarbone, which is the clavicle bone. So in the anatomy and also in the X-ray view, you can appreciate these structures, the body structures. As for the joints, so we do have a lot of joints in the shoulder region there. You have the joint between the acromion process and also the clavicle bone, which is called the acromioclavicular joint, or popularly known as the AC joint. Next, you have the glenohumeral joint. This is the shoulder joint proper. Okay, the movements of the shoulder joint will be reflected in this joint itself, majority of them. And then you will also have the sternoclavicular, which is actually more of the proximal clavicle with the sternum. This may be affected, especially in conditions just like clavicle bone fracture or dislocation, subluxation, which can cause, can mimic some chest pain. And finally, the scapulothoracic joint or the girdle. This is actually quite important with regards to the musculature, the core muscle, and also to improve the range of motion, because the final movements of the shoulder joint is actually movements from the scapulothoracic joint. Therefore, as you know, the shoulder is hanging by the side. The arm is actually hanging by the side of the torso. So it needs stabilizers to stabilize the arm to the torso. So these are called the static and dynamic stabilizers. And for static stabilizers, you have the bony architecture, the bone cell, the tissues, which is the capsulo-ligamentous complex, and then you have the glenoid labrum. So this keeps the shoulder intact or stable while in static. While during movements, these are the functions of the rotator cuff muscles. As for the bony structures, especially more for the glenohumeral joint, you have the so-called the cup and ball shapes. This will, although is quite shallow, but this forms the basis for the joint of the for the glenohumeral joint. Next, you have multiple or many capsulo-ligamentous tissues which holds all those four joints together, right from the acromioclavicular ligament, which stabilizes the AC joint. Then you have the coracoclavicular ligament, again as a support stabilizer. You have the coracoacromial ligament. Then you have the coracohumeral ligament. And you do have all these, the superior, middle, and inferior glenohumeral ligaments, plus the joint capsules, which keeps the shoulder joint stabilized, along with the muscles on the periphery. As for the muscles, so on the front view, you have the subscapularis tendon, which is the internal rotator of the shoulder joint. And then you have the supraspinatus tendon, which you can see in the front and also at the back here, overlying the supraspinous fossa, plus the infraspinatus and also the teres minus. So at the posterior, plus the posterior spinatus portion is the external rotators for the shoulder. Okay, so as you can see, based on the position of the arm, so it determines the stabilizers of the shoulder joint. So what you call arm in mid-range motion is actually the arm hanging by the side and also arm in mid position. So between 0 to 90 degrees of abduction, these are the action of the mid-range stabilizers to stabilize the joint. And then you also have the end-range stabilizers, which is actually the arm being at the end range of motion on a full abduction. So during the mid-range stabilizer, so the arm is actually hanging by the side with a negative intra-articular pressure, which stabilizes the shoulder joint. Okay, so this is the formula. The pressure is proportional to joint volume over the arm load times joint capsule material. So when there's a patient with the so-called condition called multi-directional instability, the thin joint capsule and also the increased joint volume because of the lax capsule increases the pressure from a negative intraarticular pressure, so will become less negative. The suction effect will be reduced, causing the shoulder to become more unstable. Again, when the arm is in the mid position, then the shoulder muscle will fire the tendon, okay, or the impulses, which produce again compression, force to the shoulder, and stabilizes the shoulder joint. While at the rim of the glenoid, it is deepened by the labral tissue at the periphery of the glenoid. Again, this makes the cup more hollow and stabilizes the shoulder. Okay, so in patient who has multidirectional instability, they have a shallow glenoid socket and also poor elasticity, causing disturbed muscle coordination. So again, for the end range stabilizers, most of the time, these capsulo-ligamentous tissue are very active at work. So as you can see, the superior glenohumeral ligament is the inferior stabilizer, while the middle glenohumeral ligament is the anterior stabilizer along with the anterior band of the IGHL, the inferior glenohumeral ligament, and then also the axillary pouch. So this stabilizes the shoulder joint in the anterior, prevent the anterior motion. And then you also have the posterior band of the IGHL, which stabilizes the posterior part of the joint. As for the anterior stabilizers, the IGHL, inferior glenohumeral ligament, forms a hammock. So this is especially tight during shoulder abduction and external rotation. So you can see the representation here. So once if there's a break, there's a tear, or there's a loosening, then there's a tendency for the humeral head to get anteriorly displaced. So this is the scope representation again of the anatomy of the ligaments. Another picture, again the diagram to show the importance and the complex structures which are present in the shoulder joint. Okay, something about the labrum. Okay, so the labral tissue has its supply from the blood vessels right from the capsule and the periosteum of the bone. And then this is the labrum, the periphery here. Furthermore, the superior and the anterosuperior labrum are mostly polyvascularized. That's why when there's a tear around this area, normally called as slap lesions, it heals poorly and again a cause for the shoulder instability. Furthermore, with increase in age, the vascularity and number of chondrocytes tissue around the glenoid labrum there reduces and weakens the tissue. And this was first described by Andrews et al. In 1985. It's quite a long time back. And this is where the, again, basis or treatment of this slap lesion. Therefore, in shoulder pain, most important is the presentation and the history. So you can determine the condition of the patient or the cause of the shoulder pain by the demographics, okay, which are age-wise, gender, in certain situations like traumatic injury, most likely it occurs more frequent in male as compared to female. Okay, and then you do have the presence of comorbid medical and psychosocial conditions, like if the patient has hyperlaxity syndrome, or does have conditions of epilepsy, which can cause us recurrent shoulder dislocation. All right, or the patient's previous accidents or motor vehicle accidents, or even for that matter, sports injuries. And then you also have hand dominance. Well, it's mostly related to the traumatic injury, but it can also lead to overuse conditions or overuse disorders. And most important is the mechanism of injury or onset, whether it's acute, it's chronic, or it's a systemic. So all these things is actually very important. Okay, so that's why when you question about the pain, the best is actually to determine the full character of the pain, whether this the quality of the pain, whether it is actually dull aching pain, which can be due to shoulder pathology, and then you can also have burning electric type pain, which could be of cervical or neurologic origin, and then what's the progression of the pain, whether it's mechanical pain or it's a resting pain, and also whether they have aggravating or relieving factors, whether the patient, once he or she sleeps on the side of the affected side of the shoulder, that causes more of the pain, or there's overheat activities like this painful arm reduction, which could be a shoulder pathology. And sometimes the symptoms may be relieved by the arm adduction, which may denote that it's actually of cervical radiculopathy in origin. Okay, so these things actually you can consider before proceeding to the next management, which is the examination. And then also, when there is pain progression, it's quite useful to determine the cause of the shoulder problem, because like when you start seeing in the acute phase, there's a pain, which can also be acute freezing associated, followed by stiffness, or the other words for it, frozen freezing phase, and finally you would have the recovery phase of the pain, the thawing phase. So this is actually, as you know, is the frozen shoulder symptoms. Next, when you do see, when you hear the pain at the lateral region, this can be due to the subacromial or intrinsic glenohumeral pathology. Okay, the patient may have the painful arc syndrome, and also in the if the patient has pain at the acromioclavicular joint, which is around the anterior aspect of the proximal arm together and radiating to the biceps, this can be a problem due to the acromioclavicular joint or biceps tendinopathy. And then sometimes the patient will also say that there's a nighttime aching and also sleep disturbance, which is actually quite common in shoulder pathology, and most of the time, 90% of them would have rotator cuff tears or symptoms. In certain situations, sometimes you find that the patient has shoulder weakness without pain. So could it be due to nerve impingement? Okay, because one of the common reasons for it is actually the suprascapular nerve entrapment, secondary to direct trauma, or presence of ganglion cyst growth, okay, benign growth inside the shoulder joint. Okay, so when the patient comes to see you, there are certain which prompts you to refer these patients immediately to the specialist, or the pain definitely requires proper and competent diagnosis in the first place. So when these shoulder reflex are identified during this primary care assessment, then urgent secondary case referral should be done. Okay, you should immediately refer this suspected infected joint, the condition called sciatic arthritis, which can be life-threatening. This requires same-day urgent referral. Okay, this is a urgent situation, so we should be careful and we shouldn't hesitate to refer these patients. Right. Next, if the patient comes to see you with unreduced dislocated shoulder, or it can't be reduced at all in your setup, so again, you need to perform same day urgent referral, because we need to identify or determine what makes the dislocation persist or why it can't be reduced, whether there's a fracture, whether there's a tissue impinging on the joints to prevent it from being reduced. So we need to know that. Next, if you suspect that there's a malignancy or tumor within that shoulder region, then that requires urgent referral for further management. And also, if there's an acute calf tear as a result of a traumatic event, accidents, motor vehicle accidents, or even sports injuries, then this requires urgent referral to determine the severity, the degree of the injury, and in fact, to determine if there's any multi-tissue involvement, be it muscular, cartilage, bones. So it's good to refer these patients. And furthermore, if you do see patients with suspected inflammatory oligopolyarthritis or systemic inflammatory disease, just like rheumatoid, okay, or sometimes gouty arthritis, then you can refer it to the specialist, because this can also be considered as a rheumatological reflex sign. Okay, having said so, we shouldn't neglect the origin of the pain coming from the cervical region, because this is also one of the common causes for shoulder pain. So first thing, when you see the patient, you also have to exclude the neck cause and then get the proper history, whether it is more of a chronic or it's an acute or it's a traumatic. And then finally, one way to rule out the cervical causes for the neck pain, you can perform the Sperling's test, where you apply a downward pressure on the head and then extend and rotate the neck of the patient to the side of the pain. The test will be positive if there is a pain of the upper limb or the presbytia is present. And be in mind, actually, neck pain alone is not really a positive sign, because it's actually non-specific. So you need to get painful limb, upper limb, or paresthesia. Then the test will be positive, which shows that this is actually the shoulder pain is due to the cervical radiculopathy. And this test also has a high specificity for it. Coming to the local shoulder causes. So first we have the shoulder instability. So as for the incidence, the traumatic instability is around 1.2 to 2.4 per 10,000 population in a year in the general population. But in cases of subluxation, in dislocation with at-risk populations, it can be higher. As in the military recruits, you would have around 1.69 over 1,000 patient years. and most of them are actually anterior instability, with the rest being shared between the posterior instability and so the remaining 10% multi-directional instability. Here, the patient presents with loss of the shoulder curvature, and sometimes you have also with reduced sensation around the regimental patch. Okay, so this is to again to exclude axillary nerve injury. So the patient usually will have difficulty to move the arm, limited range of motion, along with severe pain. And if you perform the X-ray, you can see that the humeral head is out of socket. Okay, and do look for any involvement of fracture to the neighboring structure, the glenoid bone or the humeral head. There's a also called compression depression, the heel sac lesion, okay, or the reverse heel sac, or for that matter, if there is any acromioclavicular joint dislocation. So do look this in the X-ray images and always doing two planes of X-rays. So usually for shoulder instability, if there's only a single episode of instability and once it can be reduced, the patient can be treated at your center with by just resting the arm, with the use of arm sling, and limit the movements, probably for around 2 to 3 weeks. The best is within 1 month, and then you can cover with analgesics or painkillers, and if needed, physiotherapy can be advised. So, coming to the after the shoulder dislocation, if it turns out that it's always dislocating after it, or patient does have pain with the signs of instability, it can also be due to the Bankart lesion, which is the tear at the inferior part of the glenoid labrum. And this will in turn cause anterior instability, recurrent dislocation, and also pain due to the limitation of the shoulder movements. And this Bankart lesion can either be a soft tissue or bony avulsion, meaning can be from the labral tissue, or it can also be a break of the glenoid bone together with the labral tissue detachment. So if this happens, then one of the treatment should be surgical treatment to prevent it from recurring is the repair of this Bankart lesion. Okay, so the other tissue, or basically the other tear around the labrum, more so on the anterior-superior, is called the slap lesion. As you know, again, due to the poor vascularity and as the age increases, there's a lesser possibility for the tissue to heal. And based on the classification, the arthroscopic treatment will be directed towards this degree and severity of the injury. As I mentioned, sometimes with the shoulder dislocation, namely again with a recurrent dislocation, there may be a possibility of a bone loss to the glenoid bone, the anterior glenoid bone loss. So this you can actually pick up during the X-ray, or sometimes normally either by the CT scan or the MRI. This will determine later on whether this problem has to be addressed. As you can hear before, the heel sac lesion is the fracture anterolateral aspect of the humeral head, which was depressed once the shoulder has dislocated anteriorly. It gets impinged on the glenoid bone, and this will cause a marked depression to the humeral head, and will also form an instability to the shoulder joint. These are some of the principles when we treat the patient, whether the patient requires type of surgery, whether it can be a surgical labral repair of the torn labrum, or the patient has to undergo any other procedures like bone plug, or the filling of the bone defect, or the other techniques, so-called remplissage. So this will be determined by all the other criteria or factors. So as you can see here, this is a short protocol. If the heel sac is not engaged or is not jammed inside the shoulder, then doesn't require any treatment to that particular bone. But if the defect to the glenoid bone is more than 25%, and then there's always jam, then you need to put a bone graft. Okay, or you can do a coracoid transfer. Okay, this is together. Right? Okay. Next, if it's purely glenoid defect of around less than 25%, then either you can do a coracoid transfer. This is sometimes what requires the Latarjet procedure, or you can even do the remplissage. These are all actually surgical management to prevent dislocation again. So I normally routinely do, if it's an operative intervention, then the shoulder will be placed in a beach chair position. So it's just like a person lying on a deck chair or big chair, but this patient is already been fully anesthetized under general anesthesia and properly being draped. I normally use the so-called spider apparatus, which holds the arm in position in a serial manner. So that will this will help me with the third hand. Okay, so for the band cut repair, so when you have this band cut lesion, the tear of the glenoid labrum detached away from the glenoid bone. So the concept or the technique is just by fixing it back, bunch it into a small bump and close and approximating together, narrowing the capsule, and at the same time deepening the labrum again, and also stabilizes the shoulder. These are actually a series of depictions showing the techniques of arthroscopic stabilization repair. To begin, you identify the labral tear. If it's been detached far away and due to a scarring, so it's in a so-called abnormal position, you have to detach that. Okay, using an awl, detach the tissue, and then make it raw the surface. Put an anchor, suture anchor, which is a so-called biodegradable screw with sutures trailing to it, and with these sutures, you tie up. You pull up those released glenoid labral tissue, and you tie up and form the bump. Okay, so you do normally for the Bangkat lesion around 5 o'clock, 7 and 9, 5, 6 and 7. If not, 5 and 7. Next, coming to play is the acromioclavicular joint disorders disease. This can be acute or chronic. So when you have an acromioclavicular joint injury, so these ligaments are mostly involved, namely the acromioclavicular joint between the acromion process and the clavicle, and also you have the equally important, the coracoclavicular ligament. So these two holds the clavicle in place whether in a coronal or sagittal view, which is preventing it from translating upwards or sideways. And normally, patients who get this injury, AC joint injury, are those involved in contact sports, namely rugby, football, basketball, in fact, for weightlifters. And this is actually a direct fall onto the shoulder in an abducted arm, fall on an outstretched hand, downward force on basically on the hand itself. So in an acute situation, you have the AC joint dislocation, okay, where the opponents may have actually struck directly to the shoulder of the patient, and which leaves the patient in pain, or you can see a deformity at the shoulder joint there. So here, as compared to the shoulder dislocation, you have an AC joint dislocation. You can see the uplifting of the lateral end of the clavicle as compared to the normal side. Especially so if the severity is of a severe degree or stage. You can see the rupture of the ACL, of the acromioclavicular ligament, together with the coracoclavicular ligament. Okay, the conoid and the trapezoid branch of those ligaments. And also from the severe view, you can also see the anterior and the posterior movements of the clavicle. So you can see there's a gap, and sometimes if you do not appreciate it well, you can use the weight bearing view, so that the patient's one he holds a weight, then you can see there's a separation of the AC joint as compared to a normal side. Okay, so again, in orthopedics management, you do have the classification on how of this AC joint injury to determine the types and management of the treatment of the patient. So usually for the type 1, type 2, and type 3, meaning that there's a minimally displacement or stable AC joint, treatments are usually conservative. Patient will be given analgesics, arm slings, and also perform physiotherapy as needed. And in selected cases of type 3, type 4, 5, 6, and 7, then it is recommended for an operative repair, mainly for quality of life, return to function, okay, so that it doesn't get delayed. Furthermore, if there's a chronic history of chronic dislocation, then as surgeons, actually, we don't recommend just purely repair. So it requires biological reconstruction of the AC joint. So this I have performed from time to time, depending on the situation or when the time arises. So this is for the acute dislocation of the shoulder joint, AC joint. So the current treatment, besides the use of the hook plate, conventional hook plate, which requires removal and is really static, which may cause a lot of side effects or complication if not being done properly. So the current technique is by using the tightrope stabilization, meaning there's two implants, hook placed on top of the clavicle bone, another one at the base of the coracoid bone, and with a suspensory stitches, so-called wire-like stitches, approximate these two ends together, the CC ligament. So this is actually very important for the reduction of the AC joint. And also nowadays, we also repair the AC joint somewhat in a similar manner. Okay, coming to the symptoms of a painful arc. Okay, so in acromioclavicular disorder, most of the time the arc of pain initially will be increased. The pain will be increased for a range of motion between 120 to 180 degrees. While if there is a painful arc of between 60 to 120 degrees of reduction, then most of the time the injuries or the disorder will be at the subacromial region. Along with the pain, you have the diurnal variation, increase at night, or basically how you move the shoulder joint. So you can see, so between the range of motion beyond 120 degrees up to 180, then this is actually the cause by the AC joint. Okay, and it's actually the mid-arm region, the arc. This is namely due if the abduction is from mid-arm until up to maximum around 130 degrees, then it's due to the subacromial problems, the impingement syndrome. So when you have this acromioclavicular disease or disorders, one of them being arthritis. So since we have a joint in between the clavicle bone and the acromion, this can also lead towards arthritis and cause painful symptoms to the patient, severe and unrelenting. How do you determine this AC joint chronic disorders? You can perform the cross body duction test. Okay, abduct the shoulder joint and then reach for the opposite shoulder blade. Okay, and this will cause certain degree of pain around the AC joint of the affected of the ipsilateral hand. So this is a very good diagnostic value for isolated AC joint disease alone. So in fact, it shows the greatest sensitivity of around 77%. As you know, there's 1,001 shoulder examinations, but the problem is that the results are very ambiguous. So if there is, in spite of the treatment, the patient do still have pain, one of the ways that we can treat the pain around the AC joint is by giving direct steroid combined with lignocaine to the AC joint. This may relieve the pain of the AC joint. And it can also be a diagnostic value. Okay, so again, with the shoulder pain or basically with the AC joint injury, one of the reasons for the cause for the shoulder pain due to trauma. Now with the end or nearing the end of the MCO, again you'll see the group of cyclists on the roads. All right, so there's always a tendency that there'll be a collision, there's an accident, and one of the injuries that usually that comes to your clinic setup after a fall, it could be the broken clavicle, collarbone in layman's term. So again, you may see a deformity of the clavicle bone. All right, you can see the jutting out just underneath the skin. Okay, and also because of this, there's a collection of blood, hematoma, so you can see bruising. Okay, and this can either be treated non-operatively by just getting the arm sling. Okay, if the bone after the X-ray being performed is with a minimal displacement, or if the patient is not fit for surgery, so you can treat non-surgically. And also if there's no open fracture or no neurological problems following the accident. Okay. However, if the patient has a tendency wanting an early mobilization of the shoulder joint, and cosmetic purposes usually, to avoid significant deformity, shortening of the bone, and of course you can't delay if it's an open fracture. And also, again, it is to avoid injury to the AC joints. If the person works in the requiring carrying heavy loads or very strenuous activities. So an example here, you can see that this patient has fracture of the right clavicle, traumatic, and also uh, the AC joint slightly disrupted. Normally it's around 2 to 3 millimeters. And also the measurement, it has a shortening of around 2 centimeters. So there may be a possibility that the patient will develop chronic AC joint pain later on, okay, due to the shortening of this clavicle bone. And he's a right hand dominant. So she wishes for surgery. So surgery was performed, and with the alignment and the length being corrected. So that will relieve the symptoms of the AC joint to begin with. Okay. Next, we have the frozen shoulder, or the other terms called as adhesive capsulitis. Okay. But normally, frozen shoulder is usually reserved for uncertain etiology, meaning that you don't have any causes for it to cause this shoulder pain. And what happens that it clinically significantly restricts the movements, the active and the passive shoulder motion movements. And this is occurs without the absence of a known intrinsic shoulder disorder. Okay, if there's no history of diabetes, there's no history of so-called trauma to the shoulder. So this is the term that has been called. And what is actually the pathophysiology? So this is actually the inflammation of the capsule, the tissue, the joint lining. So the scar tissue forms around the joint capsule. It becomes thickened, stiff, hardened, which restricts the movements. And normally it is usually can be due to the previously incomplete heel injuries like fracture, fall causing a fracture to the humeral head, or for that matter, the clavicle. Right, this can lead to frozen shoulder later on. You have the acute phase, which lasts up to 9 months, and there is actually the painful restriction in all motions. All right, so the patient will usually comes to see you within this period, and then if it's not treated early, then again there will go towards the second phase, the freezing. Okay, freezing phase, which occurs after the 4th to the 12th month, 1 year. Okay, so there is already a reduced active and passive motion. The pain will be lesser, but sharp pain will occur during the range of motion. And now, because it's already close to half a year, the wasting of the muscle becomes more prominent. Finally, you have the resolution phase, the phase 3, which occurs for between of duration 5 to 12 months. So to be exact, probably around 1 or 2 years after the initial two phases, there may be a gradual improvement of the range of motion. But then again, the joint will already be chronically stiff. Pain wouldn't be too much, but again, with a passive range of motion, then the pain reappears. So this is the frozen shoulder. So mostly affected the joints is actually the external rotation. All right, first and most severely affected, and then followed by the abduction, internal rotation, and flexion. Most of the time, the extension and horizontal adduction is disaffected. But then again, with all this restriction of movements, more than 80% of the glenohumeral joint will be lost. So that's why you have patient having pathognomonic of a frozen shoulder being limitation of the external rotation. So for the condition, it usually lasts up to 18 months on average, but can be longer. So most important for this patient primary care treatment is mostly pain relief and prevention of further stiffness. Namely, you can provide analgesics, anti-inflammatories, and then again, if required, you can give steroid and local anesthetic injection into the glenohumeral joint to relax the tissue, again as an anti-inflammatory, and also by performing physiotherapy. So this you can start at any duration. Okay, this is an example of how you inject. You mark the area. You can see the acromial process, the spinal scapula, and then you see the clavicle, the coracoid process. So around 3 or 4 centimeters inferior to the lateral border of the acromial process, you direct the needle towards the coracoid process, okay, and then you inject it. Probably first you can use a local normal saline water, just to inflict the pain to confirm the location. Then you can later inject with steroids. Okay, if all the consultative treatment fails, then the operative treatment will be manipulation of joint under anesthesia, followed by arthroscopic capsular release, where you put camera inside the glenohumeral joint and cut those tissues, the capsule which is thickened, and also cutting those glenohumeral ligaments. So this is a sequence of photos showing the thickened capsule. Okay, 1, 2, followed by the release by using the diathermy here. Okay, the final end result. Finally, the most common problems with shoulder pain, around 80%, 85% of them. But this is again based by upon history. So once you non-linear you elicit those based on history, this is usually the presentation which the patient may end up with. The reason for the shoulder pain. So the patient may actually presents to you with a gradual impingement pain, light pain, and shoulder function loss. And this rotator cuff test, or CT, sorry, increase progressively after 60 years. So around if more than 60 years, there's already a risk of 11% of them getting. And when the patient turns up around 70 years or 80 years, the incidence will go up to more than 50%, or even sometimes up to 80 to 90%. And while this rotator cuff test is actually is an end result to an accelerated aging process. It's more like overuse, wear and tear. So, namely, it's quite common, and these patients can in fact be treated successfully with conservative treatment, meaning you treat with painkillers, analgesics, rest, again, physiotherapy. However, if the patient is physically active, irrespective of the age, young and old, and having an independent life, then cooperative treatment may be an option, or can also should be an option. So, in cases of overhead activities like playing golf, okay, for example, then the person may suffer the pain. This can be either due to a traumatic event, or can be due to a chronic overuse degenerative conditions. So you have the shoulder muscles again, the subscapularis, then you have the supraspinatus tendon, and also you also have the back muscles, which is the again posterior part of the supraspinatus, infraspinatus, and teres minor. Okay, you can see there's a break to the tendons whether it can be the anterior muscle or the posterior superior muscle. Again, there's also a break at the posterior muscle here. Okay, the posterior part of supraspinatus, the infraspinatus. So how do you rule out the supraspinatus tear? You can do the Jobs test or the empty can test, where you keep the hand at 90 degrees of abduction and then 30 degrees of forward flexion with the thumb pointing downwards. And then you ask the patient to lift the hand up straight against resistance. So if there's pain, then basically, or weakness, it's actually a sign, it's a positive sign for this supraspinatus tear. So quite pathognomonic. Okay. So namely, in X-ray you don't really see much. So once you refer to the consultant or specialist, and it's most likely that we will order MRI if it's already been confirmed clinically and by examination, confirmed by MRI to see if there's any neighboring or any other additional tissue injuries. Indeed, it can be a cartilage injury, or there can be a condition caused as an impingement or the bursitis tissue, yeah, which may need to be addressed once the patient undergoes surgery. So if the surgery is contemplated, so one of the protocol treatment to repair before repairing the rotator cuff is actually to do an arthroscopic decompression. Because one of the reasons for the chronic rotator cuff, as you see here, RC, is actually due to the prominence or the osteophytes. They call it subacromial. Okay, so you need to decompress. One is you need to shave off the bone, all right, widen the space, and then you remove the bursa, the yellowish thingy here, which can also be a brick wall crushing the muscle, and then only you can expose the calf muscles. You can see the quality, the external tear. And once you see the calf tear, then you can perform the arthroscopic calf repair. You can do it either under keyhole procedures or you can do it under the mini open technique. Right? So this is how you do it. Once you identify the calf tear, insert the suture anchors, and then you close the gap, repair, fix it firmly to the bone attachment or to the incision. Okay, I'll be sharing with you some examples. Here is actually the 50-year-old male, left-hand dominant, who had initially seen a cardiologist for the left shoulder pain. So he had done all the necessary investigations. Finally, the cardiologist referred to me because he had done MRI. So because the MRI had shown certain findings of the calf muscle. Okay, but you can see here that there's a so-called narrowing of the space in between. So this is also the reason for the tear, right? The front view, and also the Y or the lateral view to rule out any other possible causes. And so once the MRI has been performed, this is the axial view, followed by the coronal view. It shows actually the tear of the rotator cuff, which is the cause for why he's been having this left shoulder pain. So since he's been having this shoulder pain for the past 6 months, he opted for the surgery. So once the subacromial decompression has been performed, I can really see the tear of this supraspinatus tendon. This is by putting camera from the back, from the side view of the shoulder, and this is from the posterior view, putting the camera at the back. This is the standard viewing portal. Then, again, by doing an arthroscopic procedure, fixing and suture anchor, and then stitch, grabbing the tendon, stitch with the trailing stitches, and fix it to the bone. Okay, again, there's another case of a 41 years old male with right shoulder pain. Again, chronic pain. X-ray doesn't really show much, okay, but you can actually do angle. We can measure the angle, the so-called critical shoulder angle, which can actually give me a hint, give me an idea whether there's a tendency of a patient to have a rotator cuff tear, right? So how it's being measured is from the tip of the glenoid up to the inferior border, and then extend towards the lateral aspect of the coracoid process or the acromion, and this will give me the angle. The normal angle is around 30 to 35 degrees. If it's less, what they say is based on studies is that there's a tendency for osteoarthritis of the glenohumeral joint. If it's more than 35 degrees, then there's a high possibility of having rotator cuff tear. This is by just by the X-ray of the shoulder joint. Next, following the X-ray, MRI was performed. Again, actually there's a tear around here, around the posterior part of the supraspinatus tendon. And then this is a series of the photos that was taken. Initially, the diagnostic around the glenohumeral joint, because patient do have a bit of the limitation tenderness around the glenohumeral joint, a bit of cartilage injury, and then once the subacromial the bursa has been removed, that's actually the tendon around here, which is a torn, small tear, and that's where again the arthroscopic repair has been performed. It's been closed, right? And then you have the final example that I'm sharing with you today. There's a 45-year-old man who's right-hand dominant, who does a lot of gym exercises, and he's been complaining of pain around the shoulder region, uh, not only to the rotator cuff area, but also to the AC joint. So again, X-ray shows there's a bit of the AC joint arthrosis. Okay, the space appears to be normal. Once the MRI has been performed, you can see here, this is actually, there's a cyst around the bone together with the tear of the tendon here. There's an avulsion tear. And also the AC joint arthrosis. So what's being done? Again, the subacromial decompression, remove the tissues. And then finally, this is the tear, which is seen. And then again, it's being repaired. This is the remaining trailing sutures. It first is being stitched to the tendon, and then anchored or pulled back. The tendon is pulled back by the anchor sutures and fixed back to the incision of the humeral head, the proximal humerus. While the AC joint was given a steroid injection to relieve pain, since the patient doesn't want any surgical intervention at that part. Okay, equally important is actually the rehabilitation of the rotator cuff. Sometimes, most of the time, if there's a cuff repair, the hand has to be kept at the abduction position using the slingshot. There's a cushion and there's the arm sling. And then once the tissue has recovered, they have to undergo physiotherapy to avoid stiffness and also for muscle strength and also return function. Finally, just to summarize the common causes of the shoulder pain, this is from the shoulder elbow surgery here, pathway protocol. So as you look at the 11 o'clock, the upper left border here, the cause of the shoulder pain should be ruled out first, whether it's a neck or the shoulder problem. If it's neck, normally the pain not around within around the neck region and also up to the interscapular region. Okay, and also if sometimes what happens can also occur at the head, radiating pain to the head and the forearm. And then you can also perform the Spelling's test, all right, to negate out the cervical causes. And if it's not the cervical, then it should be the shoulder. So, but before that, you must also rule out the reflex. You must also remember about the reflex, because thinking that if these are present, then you need to urgently refer the patient. Okay, so if the problem is due to the shoulder, when there's a history of instability, yep, you can treat it. Okay, but you refer the patient, yeah, if there is a traumatic dislocation or the systems has been persistent or the patient does not improve in spite of the conservative treatment. Okay, when you examine next after the glenohumeral joint, it's actually the AC joint, so you can determine the range of motion, and if the pain is actually localized to the acromioclavicular joint, plus there's a positive cross arm test, yeah, then by doing investigations, X-ray at least, if you elicit that the problem is from the AC joint disease, then you can treat in the primary care setup with the conservative treatment. Okay, I normally do X-ray, just to make sure that there's no other problems. However, if the pain, if there's no improvement at all, or the pain worsens, then I think best is to refer to the specialist or consultants. Okay, okay, but based on the history examination, you notice that there is actually the shoulder pain. There's actually the reduced passive external rotation. Okay, and this is coming from the glenohumeral joint. So most likelihood is the frozen shoulder, right? Most common problems. And if you do X-ray, there's no pathology, there's no history of fracture, then you can treat conservatively, those as and when required. Okay, but again, if it fails or you feel that it requires referrals, you can do so immediately to the consultants. Finally, if there is actually there's a painful arc of reduction, okay, or you do the MT-CAT test, yeah, the Jobs test is positive, okay, so and yeah, if there's and the impression is a rotator cuff tendinopathy, again you can treat conservatively, okay, if needed. But if the patient, again, if there's no response or if there's an increase in pain or the rotator cuff tendinopathy, you can refer those patients, whether immediately, especially because those patients, our Asian patients, tend to withhold their pain for, if not many weeks, to be many months before they come and see the doctor. So usually when that happens, and when those patients are were referred to me by the GPs, most of the times there's always higher options for surgery. Okay, thank you very much. Okay,
Okay,
yeah,
close.
Lucy.
Finish, right?
Yeah,
Okay. Share.
share.
Let open the minimize first.
Sure.
Yeah, minimize. Can close. Which one? The first one. This
Yeah.
one? Okay, open.
Okay.
Okay, make it bigger.
You can see window.
Okay. Pause first. Okay. Okay. Go to video file. Okay.
This one.
No,
No, video file.
you can go to share screen. Share.
Okay.
Okay.
Huh?
Okay.
Yeah.
Okay.
Okay. Yeah. So this is actually a video of showing the rotator cuff muscle. Once there's debrided, you can see the tendon itself. Okay, you can see that this is a pristine rotator cuff tendon. There's no obvious tear yet, so you can see just a mild cuffing. The other one.
Minimize. Close.
file. Share screen. Okay. The other space. A space where the subcommunity compassion and also bisect to the tissue, yeah, to the tendon. If there's a tear, then I will address it accordingly. Okay.
All right. Thank you, Dr. Samsul. It was a very informative session. We will go ahead and take some questions, some time for the questions now. Dear doctors, just a reminder, please be sure to type your questions in the question box in your control panel. Let's Dr. Samsul, let's wait for 2 minutes to get the questions. Was a very informative session. We will go ahead and take some questions. Sometimes the questions. All right, doctor. Looks like we have some questions here. So the first question is from Serene. So her question sounds this way. For recurrent of anterior dislocation of shoulder, does it warrant further investigation?
Thank you for the questions. So, when there is a recurrent shoulder dislocation, we have to determine what is actually the cause of the recurrent dislocation. Yeah? So, most of the time, uh, if there is the recurrent dislocation, if this is just more than 2 or 3 times, there's always a likelihood for the dislocation to occur more, to recur. Yeah. So, of course, one is that it means that the labrum or the slap lesion, plus the so-called the bony Bankart, the bony injuries. Therefore, this does require further investigation. Okay, or in certain patients who has multidirectional instability due to their conditions called the hyperlaxity syndrome. So this will be investigated properly and also then only be treated accordingly. Okay, so sometimes especially in multi-directional instability, then I think first things first is to treat consultantly, but there's always a provision for surgery for that. Thank you.
All right. So the next question, doctor. Af- After reduction of dislocation, does the arm need to be in the arm sling or in a certain position?
Okay, thank you for the question. Well, I think the best or the routine way is that after dislocation, you just rest the arm either by putting in an arm sling or making a sling. This will in turn will provide rest and relief for the patient. Yeah, of course, in studies and the orthopedics or the sports journals, there's certain adduction position required. But again, most of the outcomes actually not statistically significant. So you may put the hand in arm sling. Okay.
I see. Okay, doctor. In view of the time, we could only pick a few questions before we can come up. We can come to the end of our session. Doctor, is there anything else you wanted to cover before we wrap up the session today?
Yeah. First things, I would like to thank to all the viewers, my colleagues in the GP practice, for taking your valuable time to hear the presentation. And I hope that you learn something useful during the presentation, and know that when to treat the patient or when to refer, especially in cases like septic arthritis or acute traumatic unreduced dislocation. And yeah, I think the difference between a frozen shoulder, okay, or rotator cuff tear. So this is actually something which is, I think, we all should know. But and also once it requires referral, I think um, that can be done. But hopefully you benefit from this session. And if you do have any questions, you can actually what do you call? You can actually email me, or you can contact the hospital. All right. So I'm happy to answer your questions. Well, we can take some questions if it's possible. Which questions? Okay, so there's one question here. Uh, well, I'll try to answer as much as possible. So, as for the special test for the shoulder joint, rule to rule out impingement, which are the common special tests? Well, if you know the impingement test, the passive, where you bring the hand inwards, I think at the end of the day, it's actually nothing which is very conclusive. Again, like I say, there's a multitude of tests, so you have to do more than one test, if not all, and then to determine the condition, the so-called impingement test. Okay, and then how to prevent shoulder injury during sporting activities. Well, first things first, you need to do some warm-ups or stretching, and avoid from overusing. It means that if there's any pain, most of the time, either that you have been overusing it or the technique may be wrong or maybe imperfect. So you need to see on that. Okay. Questions from Dr. Jayaram. What exercise do you recommend for those with conservative management of rotator cuff injury? Can they swim? Yeah, I think in the beginning you have to let the patient rest, because at the end of the day, these muscles are actually at stress or at strain. So you have to rest it. Most important is actually do more of the pendulum movements to avoid the stiffness. You know, uh, so that so that there are certain movements, but at the same time you do not overuse the so-called inflamed tissue. So the other questions, um, what conditions do you prefer for steroid injection? How frequent suggestible for this procedure? Well, this is actually subjective, because this all depends on the demand and expectation of the patients. We can offer this procedure to the patient, but if the patient is so-called is defensive or against injections, and normally when I perform injection also, I would perform MRI first. If if the patient is, if the condition is quite severe enough for the patient um, does not respond to initial consultative treatment. Because sometimes again, when you inject, they can actually impair or disrupt the images in the MRI. So preferably I will do MRI first. All right. Mm. Okay.
Great, Doctor. Looks like you have covered almost all the questions on the floor. Thank you so much. All right. Thank you, ladies and gentlemen. We appreciate you being here.
You're welcome.
And yes, if you have any further questions that you would want to check with the doctor, you can always reach out to Dr. Shamsul by calling to his clinic at 0378 399818. All right. Thank you for joining us today, and we'll see you next time. For CPD points, I'll be sharing the slides in a few minutes.